Hello, and welcome to this lecture on disorders of the red cell. The learning outcomes that you will gain from this lecture include these 4 points. Red cell disorders are some of the most common diseases in the world. Anemia can result from many different conditions, such as iron deficiency, hemoglobinopathy, and chronic infection. Hemolytic anemia occurs when the red cell lifespan is reduced. And increased numbers of red cells are seen in polycythemia, which may result from a myeloproliferative disease or response to hypoxia. Let's start with the red cell itself, and here is that very familiar electron micrograph of red cells, showing their biconcave shape. Red cells derive from erythroblasts in the bone marrow. They're packed with hemoglobin, and they carry oxygen deep into tissues. The production of these cells is regulated by erythropoietin, and they don't have a nucleus, so their lifespan is limited and is around 120 days. Anemia is very common throughout the world. It can be defined as a reduction in the hemoglobin level within the blood. But remember that this must be taken in relation to two factors. One is the age of the patient, and the other is the gender. Let's just look at that table on the right, which shows typical hemoglobin concentrations at different ages. If we look at the mean hemoglobin column, at birth, cord blood has a high hemoglobin concentration, around 165 grams per litre. But then the green line at 1 month shows that this has already fallen to 140 grams per litre. In the first few weeks of life, there is a lot of breakdown of red cells within the blood and change of the globin to a different form. At 6 months to 2 years, you see a relatively low hemoglobin concentration, 120 grams per litre, which then starts to increase at the age of 12 to 18 to around 140. And then look at adults right at the bottom, and you'll see the characteristic difference between females and males in the hemoglobin concentration, with males having that increment of around 15 grams per litre, due to the effect of anabolic male hormones. Now, the symptoms of anemia include a range of things, including tiredness, shortness of breath, poor concentration, palpitations because the heart is beating fast and vigorously, and of course, pallor is a sign that somebody may be anemic. A good method for approaching the classification of anemia is through analysis of the red cell volume. So let's now take a look at that in a little more detail. Here we see the classification of anemia based on the mean cell volume. So on the blue row, you will see the anemia type. Microcytic hypochromic. Those are small cells with low levels of hemoglobin. Here we have two subsets of disease that we will discuss in more detail: iron deficiency and thalassaemia. In the middle, we have normal size cells, normocytic and normochromic. These are due to chronic infection, renal disease, and marrow disease, and may also include hemolytic anemia. Whereas on the right, we have macrocytic anemia, large red cells with a raised MCV. And we'll see later on how these are normally secondary to vitamin deficiencies, particularly vitamin B12 and folate deficiency. Let's take the first of these, and that is iron deficiency. First, we have to consider the physiology of iron within your body. Now, iron is one of the most common elements in the crust of the earth, and yet we only have around 4 or 5 grams of iron within our body. There's also no mechanism for regulating the excretion of iron, and so we have to be very careful how much iron we absorb. We now think that this is the case because iron can be quite toxic in excess, and it can even lead to damage of DNA. And so the absorption of iron is controlled to levels that we just need to maintain normal physiological function. On the right, the diagram shows where this iron is held within the body, and you will see that 70% is incorporated into hemoglobin, with 25% stored in the reticuloendothelial system. Minor fractions are circulating within the blood. This is a representation of iron regulation, and we can see at the top our intake of iron is around 10 to 20 milligrams per day in our food. There are two major forms of iron that we encounter in our diet. Heme iron comes in meat products, and that's relatively well absorbed, whereas non-heme iron is more tricky for our body to absorb. In the stomach, much of this iron is reduced into the ferrous Fe2+ form, and that helps absorption. And you'll see that absorption occurs in the upper small intestine. But on the left-hand side of the slide, you will see that much of this is absorbed into mucosal cells and then shed for excretion, perhaps 1 milligram a day. Whereas around 1 milligram goes into the bloodstream, and there is absorbed and is used in erythropoiesis. So what's this iron used for? It's used largely for making hemoglobin. Let's just look at how our cells make hemoglobin. And you'll see that that is a representation of a mitochondrion on the left. And at the top of the mitochondrion, you'll see glycine and succinyl-CoA. And those are the first derivatives that come together to form the constituents of the heme. The delta ALA enzyme, aminolevulinic acid, is a rate-limiting step here, and it produces, through intermediates, protoporphyrin, this very interesting flat planar molecule. And you'll see that that comes out of the mitochondria, links with iron, and forms heme. Now, of course, heme needs globin, and globin, you see, comes from the top right as amino acids forming these chains of 141 or 146 amino acids long. As we bring heme and globin together, we form the hemoglobin, which is so densely concentrated within red cells. When we look later at hemolytic anemias, we'll take this process in reverse and see how hemoglobin is degraded and how that can lead to some of the symptoms of hemolytic anemia. Now, iron deficiency is one of the most common findings in people around the globe. And the major cause is chronic blood loss, particularly through menstruation. So women who are premenstrual, having regular menstruation, are very commonly iron deficient. It can also be the result of gastrointestinal malignancy or inflammation. And that's very important because if you see a man who has iron deficiency anemia, clearly there can't be menstruation, that is a warning sign, also in a postmenopausal woman. You must think if there is a gastrointestinal cause, perhaps a colonic tumour or even a gastric tumour. And those should be investigated in many cases, most cases. Dietary deficiency of iron is actually quite uncommon. And malabsorption can occur, and of course celiac disease is an important consideration there, but they're relatively less common than actually chronic blood loss. The treatment of iron deficiency is usually relatively easy, and it's with oral iron salts, which have been around for over 100 years. They're one of the cheapest tablets you can possibly buy. Now, some people can't tolerate oral iron. It can lead to some gastrointestinal upset. And so intravenous iron can also be given and is really very well tolerated now. Now on the right, there is a blood film of a person with iron deficiency. And you can see how those cells fit those two criteria that we described. Microcytic, they're small. Hypochromic, they're poorly hemoglobinized. You see very pale staining cells. Another feature is pencil cells, very long, thin cells, as you can see in one or two places. The second major cause of microcytic anemia is thalassaemia. The word itself is extraordinary. It comes from the Greek, the sea. And when Greek soldiers came back after the wars, they looked at the sea, thalassus. That's the thing they said. Thalassaemia gets its name because it was common in the Mediterranean. It is due to an imbalance in the production of alpha or beta globin. You need to make equivalent amounts of alpha globin or beta globin to make adult hemoglobin. Alpha thalassaemia results from deficiency of alpha chains. Beta thalassaemia results from deficiency of beta chains. And treatment, if required, is through blood transfusion, which can replace the blood. Now on the right, we have an example of electrophoresis of hemoglobin. And this electrophoresis allows us to identify different subsets of globin. So if we look on the left, the normal, you'll see hemoglobin A is dominant. That's alpha 2, beta 2. That's the type of hemoglobin in most adults in the world. Below that, a small amount of hemoglobin F, alpha with gamma, and a small amount of A2, alpha with delta chains. Now, if we look next to that, there's a patient with beta thalassaemia trait. That means they're lacking one beta globin gene, so they're still making beta chains, but the balance between too much alpha and too little beta is disturbed. You will see that the A band is reduced. What's interesting there is you can see that the hemoglobin A2 is slightly increased. I mention that because that is a very useful diagnostic test. If you have somebody who has small red cells and you think they may have a beta thalassaemia trait, then measure hemoglobin A2 and it will be slightly increased. Just to the right of them is somebody with a more severe form of beta thalassaemia, and you can see that the A band now is very thin. There is some production of beta globin, clearly, but it is very small. And here we're now seeing more production of hemoglobin F, which is useful and can help to provide oxygenation of tissues, but is not as effective in an adult as hemoglobin A. Finally, on the right, there is an example of an alpha thalassaemia, and this is hemoglobin H disease. This is quite a severe form of alpha thalassaemia. Still there's hemoglobin A, so there is some alpha globin production, but not enough, and some of the beta chains are precipitating out as hemoglobin H at the top. Notice that hemoglobin A2 is not increased in alpha thalassaemia, so we don't have an easy test for milder forms of this disorder. Now, if a patient has severe thalassaemia, they will be chronically and severely anemic. The treatment, as I mentioned, can be blood transfusions. But if that is not done to an adequate level, a patient can be chronically anemic. And that can lead to massive expansion of hemopoiesis within the bone marrow. The bone marrow tries to expand to make more red cells. And the characteristic X-ray, although now thankfully very rarely seen, is this skull X-ray showing the hair-on-end appearance. And that's due to the expansion of the hemopoietic tissue within the skull in this patient who has inadequately transfused thalassaemia. Although transfusions are effective, one of the problems is they have a lot of iron in every blood transfusion, 200 milligrams. And so you must remove the iron through chelation. That can be given by desferrioxamine, subcutaneous injections, or through oral tablets. Now let's look at a range of diseases in which the anemia is associated with red cells of a normal size, normocytic anemia. One of the most common that we see in hospitals now is the anemia of chronic disease, the anemia of chronic inflammation. This is a very interesting background. Whenever there is chronic inflammation or infection within our body, the body sequesters iron within macrophages. It starts to shut down the flow of iron within the body. Now, this leads to a reduced iron level in the blood and a reduction in hemopoiesis. Now, you might ask, why on earth does the body do this? Well, it's almost certainly a physiological, evolutionarily selected mechanism to limit the amount of iron available for pathogens like bacteria. Iron helps bacteria to divide, and here is a mechanism of hiding it away from bacteria. There are two pictures on the right showing examples of how this may happen. At the top, we have a patient with rheumatoid arthritis, and chronic disorders such as that are often associated with some form of mild anemia. And at the bottom, you'll see a bone marrow stain for iron, and the blue there represents the iron which is present within the reticuloendothelial cells. It's been taken in because of anemia of chronic disease. It's quite a nice illustration of how iron really has to be very carefully regulated within our body. Now, the treatment of anemia of chronic disease is really to treat the underlying condition. Treat the rheumatoid arthritis, or perhaps the malignant disease, or whatever it may be that's leading to this condition. And then the rest of the anemia will sort itself out. Another important cause of a normocytic anemia is renal disease, because remember that the kidney produces erythropoietin, the major regulator of erythropoiesis. You'll see on the right a chart showing this very beautiful feedback mechanism for regulating erythropoiesis. In the bottom in green, the kidney acting as an oxygen sensor and producing erythropoietin whenever there is hypoxia, releasing that, which leads to increased erythropoiesis and a correction in the red cell mass. If the kidney is damaged, it may not be able to make erythropoietin, and anemia used to be a very severe problem in patients with chronic kidney disease. Now, fortunately, we know a lot about erythropoietin now, and it's being cloned and can be produced as a molecule for injection, and it's widely used for patients with chronic renal failure and helps to increase their hemoglobin. Another time where you may see a normocytic anemia is when the bone marrow itself is involved through other diseases. Now, in this situation, you'd also see reduction in white cells and platelets. The bone marrow simply can't produce enough normal cells. This can be due to a wide range of clinical problems. I've listed some there: infiltration with leukemia, myeloproliferative disease, infiltration with carcinoma, or aplastic anemia. On the right, you'll see a trophine biopsy of a bone marrow, and I don't know if you can recognize yourself, this is a difficult slide, of what that may be, but in fact that pink tissue is metastatic carcinoma, and that was leading to anemia in this patient. Let's now turn to macrocytic anemia, where you have large red cells. The major cause here is a disorder called megaloblastic anemia. Quite a long word again, but we can easily understand it. Megalo, large, blast, the primitive erythroblasts. Look at the right-hand side and you'll see those very large purple erythroblasts within the bone marrow. Why are they large? Well, essentially, the vitamin deficiency here is limiting their ability to divide and replicate. So they're trying to expand and produce more molecules ready for division, but they simply don't make the final division. This is due to deficiency of vitamin B12 or folate. A characteristic feature within the blood film is shown at the bottom, and you'll see two white cells, which you'll recognize as neutrophils. Now, neutrophils have lobed nuclei, multi-lobed nuclei, and you will see there more lobes than you would expect, normally up to 5, but in this condition you can see more than that. It's a characteristic feature of megaloblastic anemia. Now let's talk in a little bit more detail about how this megaloblastic anemia can arise. The most important cause that you need to know about is pernicious anemia. This is now recognized as an autoimmune disease, in which the patient makes antibodies to the stomach, to gastric parietal cells, and to a protein called intrinsic factor, which is made within those cells. Now, remarkably, when B12 is absorbed within our food, it has to bind to intrinsic factor. The complex of B12 and intrinsic factor is then absorbed in the terminal ileum. You can see immediately that if your intrinsic factor is neutralized with antibodies, you won't be able to absorb B12. And I've mentioned there that neuropathy can develop. And it's certainly true that this disorder can lead to numbness in peripheral nerves, and if untreated, which thankfully we exceptionally rarely see these days, it can lead to very severe problems, even blindness or dementia. I should mention, but before we knew the cause of pernicious anemia, this was a major cause of death of patients over 100 years ago. Treatment is very simple. Vitamin B12 injections given every 3 months. You can also take high doses of oral pure B12 and hope that you've just managed to absorb enough. On the right, there's a tongue of somebody with pernicious anemia. It's often described as beefy, and you can see it certainly is sore and somewhat swollen. Now, at the bottom, I've mentioned folate deficiency. This is not an autoimmune disease, but it can also occur when there are excess requirements for folate, classically when somebody is pregnant or if they have a hemolytic anemia. And here again, a simple tablet of folic acid will prevent all of the problems. And folate is used in the same biochemical pathway as B12, which is why these two cause the same effect of megaloblastic anemia. Let me now turn to another form of anemia, hemolytic anemia. This is a very interesting condition, and we remember that red cells normally live for around 120 days. But if this is shortened due to hemolysis, destruction of red cells, then the bone marrow must respond to that by producing increased numbers of red cells. Interestingly, reticulocytes are slightly larger than red cells. So in fact, the mean cell volume within the blood increases. So this anemia can be macrocytic in some cases. Now, the bone marrow can normally cope with a shorter lifespan of red cells until it goes below around 15 days. And then really it just cannot keep up, and anemia is almost inevitable. And that is hemolytic anemia. Let's look at how that can present in a patient. Let's start with that figure on the right of somebody who I think you will agree is jaundiced. You can see the yellowness in the sclera of the eye. That is bilirubin. Why on earth would somebody with hemolytic anemia become jaundiced? To understand that, we have to think about how hemoglobin is degraded. We talked earlier about how it's synthesized. And you'll see in the diagram on the left how this occurs. Degradation of hemoglobin involves firstly the split into heme and globin. The globin is a protein, and that is broken down into constituent amino acids. We're more interested in the heme. Again, the iron has to come out, and it's recycled, but what's left is protoporphyrin, and that's broken down into bilirubin, And now you can see why patients may get jaundiced. That bilirubin's insoluble. It needs to bind to albumin, and it goes to the liver, where it can be conjugated and excreted into the gut. Some of it is actually reabsorbed and can be passed out in urine. Now, hemolytic anemias should be classified into two large groups. Disorders which arise because of an inherited abnormality, and those which are acquired later in life. Now, red cells are relatively simple cells, as cells go. They have a membrane, they have hemoglobin, and they have some enzymes. And indeed, inherited causes of hemolytic anemia can involve those three major components. Let's look at those three in turn. We now need to just look quickly at the red cell cytoskeleton. Because, of course, the shape of a red cell is defined by proteins within the cell that maintain its structure. And you'll see this cross-section of a red cell. At the bottom, we've got proteins called spectrin, which form a lattice within the cell. And spectrin is anchored to the surface of the red cell through ankyrin proteins and proteins such as band 3 and band 4.1. So these are very critical proteins for maintaining red cell shape. Well, what happens if you're born with an abnormality in the genes coding for some of these proteins, such as spectrin or ankyrin? Well, one of those disorders is hereditary spherocytosis. Have a look at that film on the right-hand side. Do you see anything unusual about it? Well, I think what you might see is some cells which are very round and darker than normal red cells. Very spherical. And those are the cells of hereditary spherocytosis. Now, these patients often are mildly anemic, and it's a very variable disease depending on the severity of the mutation and how it affects the individual patient. Folic acid can be useful to maintain and support red cell production. And if the patient is getting symptomatically anemic with a low hemoglobin, then you can remove the spleen, and splenectomy will solve the problem. It doesn't change the genetic defect, but it stops the spleen from taking out these slightly different spherical red cells. But we have to be careful because there are risks associated with taking out the spleen, particularly in children, and you have to balance the anemia against the slight but definite risk of infection following splenectomy. There are other examples of inherited abnormalities of the red cell membrane. One of those I've listed as hereditary elliptocytosis. And yes, you're right, the red cells do look elliptical in that disorder. Let's look at another inherited abnormality of the enzymes this time. One of the important ones is glucose 6-phosphate dehydrogenase, a long word. And this is more common in people from the Mediterranean and African region. Why? Because a heterozygous disorder can provide some protection against severe malarial infection. Now, this is X-linked, and patients need to avoid factors that precipitate crisis of acute anemia in this condition. Sometimes it's drugs. Bizarrely, sometimes it's kidney beans, fava beans, and that can trigger a crisis. Just look on the right of the green boxes there, and you'll see that coming in from the right is what we call oxidant stress. If drugs, infection, or fava beans lead to oxidation within the red cells, the lack of sufficient G6PD activity can lead to that oxidation, damaging and killing the red cell. And as you work your way down through that column, you will see that inadequate production of NADPH and glutathione leads to oxidation damage. Another enzyme disorder is pyruvate kinase deficiency. Again, a similar but rare disorder. Finally, the third inherited cause of hemolytic anemia, inherited hemoglobinopathies. These are very common, and we're now pretty sure that they've been selected during evolution because a heterozygous state, although it's not clinically insignificant in the patient, it provides protection against severe malaria. Malaria has had a big influence on the genetic makeup of people who live in malarial regions. But unfortunately, homozygous forms, a bad gene from your mum and your dad, can be very severe disorders. Let's look particularly at sickle cell disorders in this case. Again, on the right, an electrophoretic analysis of globin. At the top, we have a normal person, hemoglobin A dominating with a small amount of hemoglobin F. Next one down, sickle cell anemia, a mutation in the beta chain. So there's no normal hemoglobin A. What we have is hemoglobin S. I'll show you on the next slide what that does to red cells. The third one down is sickle cell trait. This is the heterozygous state. One normal beta globin gene and one sickle beta globin gene. And here we see lower levels of hemoglobin A and some hemoglobin S. That's largely asymptomatic. And at the bottom, for the aficionados of hemoglobinopathies, is someone who has a sickle beta gene and a hemoglobin C beta gene. And you'll see now you get hemoglobin C, S, and no normal A. Sickle cell anemia is a very severe disease. In that slide, you'll see at the bottom left a classic sickle cell, similar to the scythes that are used for cutting corn. Now, sickle cell anemia leads to sickling of red cells during periods of hypoxia. When the blood is deep within capillaries and becomes hypoxic, the hemoglobin stacks up and leads to sickling of the cells. This can block the blood vessels, and that can lead to a range of clinical problems, largely due to infarction and hypoxia of tissues further down. Treatment of sickle cell anemia, if needed, is with red cell transfusions to provide normal blood, or with drugs such as hydroxycarbamide, which have shown to be quite effective. Finally, in hemolytic anemia, let's consider those disorders which are acquired. They're not inherited, they've developed in life. And I think the major one I want to focus on is the autoimmune hemolytic anemias, where the body makes antibodies against the red cells. Two types of antibodies are made. IgG antibodies, which you will know are quite high affinity antibodies. They bind at 37 degrees, and they're sometimes known as warm antibodies. Look at the top two pictures on the right there. On the left, you will see something we saw, similar to you saw a few slides ago, spherocytes. That's a characteristic feature of autoimmune hemolytic anemia. And you'll notice more reticulocytes as well, slightly bluish cells. On the right, you will see a stain for reticulocytes, and that's because the body is responding due to the hemolytic anemia. The second type of antibody that can be produced is IgM. These are less strongly binding. They often need lower temperatures to act, sometimes known as cold antibodies. But they're very powerful at agglutinating red cells. Look at the slide at the bottom of the picture. You see those clumps of red cells? They've been agglutinated by these IgM antibodies. These are sometimes found in older people who have plasma cells in the bone marrow producing these IgM antibodies, and it can be triggered by infection as well. We've spent a lot of time talking about anemia, but I just want to finish off by introducing the other side of the coin, where a patient has too many red cells, and that we call polycythemia. Here we see an increase in the hemoglobin concentration. It makes the blood more difficult to pump around the body. It's more viscous. And complications here include blood clots, tiredness, lethargy, and also pruritus or itching, which is particularly seen in polycythemia vera. So I'll explain in a minute. On the right is a nice diagram to explain how to diagnose polycythemia and one of the common problems that we encounter. On the left, we see normal constituents of blood. In red is the red cell mass, and in green is the plasma volume. And of course here we're looking at the hemoglobin concentration, and it depends on the relative amount of those two. But on the left is the normal range. In the middle is somebody with primary polycythemia. Their red cell mass has definitely increased, as you can see, above the normal range. Their plasma volume remains the same. But on the right is a condition where the red cell mass has increased, but it actually remains below the normal range. But here we have a reduction in the plasma volume. So actually we think there's polycythemia because the ratio is now abnormal, although there is not actually a true increase in the red cell mass. So if somebody's terribly dehydrated, you may see that sort of picture. Let's look at how we classify polycythemia. Polycythemia, as you'll see on the left, can be classified as either a primary polycythemia due to a myeloproliferative disorder or secondary to an increase in erythropoietin, lung disease, smoking, altitude, or sometimes a tumour that's producing lots of erythropoietin and driving the bone marrow. And on the right is quite a useful algorithm for approaching patients who have potential polycythemia. You can see at the top the potential hematocrit that might make you consider that a patient has polycythemia, a male over 0.52 or a female over 0.48. Going down, you could check whether the red cell mass is truly raised, or if not, it's an apparent polycythemia. If the red cell mass is raised, are there causes of secondary polycythemia present? If that's true, it could be a secondary polycythemia. And if not, consider polycythemia vera. Now, management of polycythemia vera depends on the genetic abnormality of this disorder, which we now understand. Almost every patient has a mutation in the JAK2 gene, and we can use this to introduce new treatments. As well as taking off blood or using drugs such as hydroxycarbamide, JAK2 inhibitors, which are oral tablets, are now being used in this disorder. And I'll talk more about that in the lecture on myeloproliferative diseases. Secondary polycythemia is best treated by correcting the underlying cause, stopping a patient smoking, trying to treat the lung disease, but you can use phlebotomy, taking off blood donations if you need to. So in summary, I hope you've seen from these slides that disorders of the red cell are very common within the world. The management of anemia is dependent on making an accurate diagnosis of the etiology based on targeted treatment. But an excess of red cells can also be dangerous, and it's just important that we get the diagnosis right in those cases. Thank you very much for watching the lecture.